A very good day to you all. My name is Hugo Verreke. I'm an assistant professor in anesthesia at the University Medical Center in Groningen and at the University of Groningen in the Netherlands. I'm also a consultant anesthesiologist at the General Hospital AZ Sint-Jan in Bruges in Belgium. So today we are going to talk about the advantages of using target-controlled infusion. Target-controlled infusion is a computer-controlled way of drug administration, and the computer calculates the dose and the subsequent continuous infusion based on a pharmacokinetic model in order to predict the plasma concentration, or a pharmacokinetic dynamic model in order to predict an effect site concentration. The effect site target-controlled infusion has the closest link to the clinical effect. And because of the increased reproducibility of the clinical effect evoked by effect site target-controlled infusion, I will mainly focus on that during this lecture. So before I start, I want to point out that as shown in the National Audit Project NAP5 in the UK, which provides rather trustworthy numbers on clinical practice in anesthesia, it appears that only in 10% of cases a total intravenous anesthesia is used, and in the majority of cases there's a volatile agent used. So apparently there's still a lot of reluctance to use TIVA, and that's probably due to educational reasons, because it's not you don't have that much exposure to TIVA cases during your training. Also, the technology often is not provided. In many hospitals there still is a low number of TCI pumps or readily available, and sometimes people feel that it's more labor intensive to use a TIVA case. I do not agree. I think that's a question of organization, but still we have to acknowledge there's only 10% TIVA cases going on at this time. However, if we talk about TCI, it appears that once you have decided to use a TIVA case or to do a TIVA case, it is almost obvious that you use a TCI concept to titrate your intravenous drugs optimally. And that's reflected in this 80%, almost 80% of all TIVA cases are done with a TCI pump. And probably this number would be higher because in some centers there's no TCI pump available, and that's probably the reason why it could be even better. But this reflects that the TCI concept on its own is of value, and it's a logical choice. For me, the advantage of target-controlled infusion is closely linked to the value of the effect site concentration. So because of its importance, I will first explain exactly what the meaning is of effect site concentration, how it is developed and how we should interpret it. And then I will talk about the value of using effect site controlled TCI in clinical practice and in research. So the confusing part about effect site concentration is that it is not a real effect, it's not really a concentration. So I mean by that, it's not something that you can measure by putting, for example, microdialysis catheters into the brain and measure some extracellular fluids and then determine the propofol concentration in that fluid. You might measure something, but that has little to do with the concept of effect site concentration. So this is a bit of the confusing part of this concept. Why do we still call it a concentration? It's because it's a derivative, a mathematical derivative from a real concentration, which is the plasma concentration. So before we can describe the effect site concentration, we need a good description of the time course of the plasma concentration. And this is done in the following way. For example, if we give a certain amount of intravenous propofol, over a certain amount of time. And then we take repetitive blood samples and we analyze the plasma concentration in that blood sample. So then we can establish the time course of onset and offset of plasma concentration. And using nonlinear mathematics, we can connect the different dots and we define a curve that is describing the average onset and offset time of your plasma concentration. Now, for the volatile agents, this is an advantage because you have your end-tidal volatile partial pressure, which is also kind of a representation of the plasma concentration of your volatile, and this is more an individual measurement, whereas we use plasma concentration as a population average from several patients that have been sampled. And of course, this is not the same as an individual measurement, but at the other hand, it is something that we can prospectively validate. We can see that the models we use to predict plasma concentration have a reasonable accuracy when you use it in a prospective setting, although the models that are used to describe this curve are rather simplistic. This is a representation of the classical model that is used to describe anesthetic drugs and their time course of plasma concentration. So it consists out of 3 compartments with a different volume 1, 2, and 3, which also are connected with equilibration constants that determine the speed of exchange of drug between the compartments, and an elimination constant that determines the speed of eliminating the drug from the system. It can also be represented by this connected barrel visualization, where you see 3 barrels that are connected with tubings of different 3 barrels. You enter the drug here. There are tubes with different diameters that determine the elimination and the exchange of drug between the barrels, and you have this rapid equilibrating barrel because the diameter of this connection is large, and you have this slow equilibrating barrel because the connection is small and also the volume that needs to be filled up is large. So what happens, we enter a drug into the central compartment, and in the beginning you will see that it's going to be eliminated very fast because it can go 3 ways: towards the 2 barrels and towards terminal elimination. After a while, there is an equilibration between the fast equilibrating and the slow equilibrating compartment, and then it can only be eliminated 2 ways: towards the slow equilibrating barrel and towards terminal elimination. And only after the 3 barrels have been connected, there's a large surface of drug that needs to be cleared, and it can only be cleared in one direction, which is the terminal elimination. So these 3 speeds of elimination, which we classically see in drug elimination, especially for anesthetic drugs, is nicely represented in this model. So for every drug that we know, we can define the volumes and clearances and the diameters of your connections between the barrels. And this is just a representation of several drugs, and you can clearly see that for rapidly eliminated drugs, the volumes and clearances are completely different compared to slower equilibrating or slower eliminating drugs like fentanyl and fentanyl. Now we can even optimize these descriptions of the plasma concentration by adding demographic information into the models. So just as a theoretical example, you could consider that the large, slow equilibrating volume of the drug is depending on the total body weight, and then you could describe it as a certain number of liters per kilogram of total body weight, and that might improve the fit of your, or the predictability of your model compared to a model where you have fixed volumes. So this has been done for multiple drugs in anesthesia, for example remifentanil, sufentanil, propofol. There are a lot of pharmacokinetics models available that can be transformed into a TCI model or a TCI application. On a commercial level, we only see a limited number of molecules that are available, but still this is the basic concept behind the plasma concentration definition. So let's go back to the concept of effect site concentration. We now have a very clear description of the plasma concentration, the time course of the plasma concentration. And now we can measure simultaneous effects. For example, for the electroencephalogram, we can represent the changes in the brain electrical activity with a bispectral index monitor, for example, depth of hypnotic track effect monitor. And then you will see that the timing of your measured effect is different than the timing of your plasma concentration. And for example, you can see that the peak effect of your BIS is at another time point compared to the peak effect or to the peak plasma concentration. And also during decay of your plasma concentration, your effect is still maximal, and then the decay of your effect will happen at a later timing compared to the decay in your plasma concentration. So again, we see a clear time delay between your measured effect and the changes in your plasma concentration. This is the case for every effect that we want to measure. And for example, we could do the same exercise with the continuous measurement of the blood pressure. And if you look at the changes in your mean arterial pressure compared to the same plasma concentration timing, you can see different timings with different time delays between your peak effect in the plasma and your peak effect on the blood pressure decrease. And so for every effect of interest, we need a different effect site concentration descriptor. That's very important. An effect site only represents the time course of a single effect. For some effects, we don't have a continuous observation. For example, you can do a shake and shout maneuver, a stimulus to your patient, and you can have a look if the patient responds or not. You can only have two situations, either the patient responds or he does not. So this is a dichotomous data point where you only have a 1 or 0. And how do you translate this in a measurement of effect timing? Is by observing this in several patients, and you see that some patients will respond at low concentration, and even at high concentration some of these patients will still respond. Of course, the higher the concentration, the more non-responders we see, and when the drug is decaying, you will see that patients start responding again. And you can translate this kind of data with a logistic regression to a continuous curve, and again you can then estimate the difference in time course between the probability of tolerating a shake and shout maneuver and the timing of your plasma concentration. Another way of representing the time delay between your plasma concentration and the measured effect is this way. When we induce a patient by administering a continuous infusion of propofol, you will see a decrease in the BIS over time. And for example, at a certain time point, you will see loss of consciousness, and this will be at a certain plasma concentration. This is just an example, 5.4 micrograms per milliliter. Next, you stop the pump and you let the drug be eliminated from the system according to the three-compartmental model pharmacokinetics. What you will see on your BIS effect is that the BIS will increase again, but only at much lower concentrations in the plasma compared to what you would see during induction. And also return of consciousness will be at a much lower concentration compared to during induction. And this is why we need a solution to have a better target compared to plasma concentration in order to have a better control over, in this case, the BIS effect. So how do we solve this dilemma? We have added a mathematical solution by constructing a theoretical volume called the effect site with a negligible, very low arbitrary set volume. The fact that it has a volume or not is not very important. It's just because we want to talk about a concentration that we need a volume. If you need an amount of milligrams and you put it in a volume, then you have a concentration. So it's just a way of defining the new target that is maybe practically more useful. Now the driving pressure for this effect site timing is the central compartment concentration or the plasma concentration. This is your driving pressure, and then based on your measured effect you can determine one elimination constant, the K0, and the K0 applied to your plasma concentration will result in a new time course of a new concentration, which is called the effect site concentration. And this one would have a much closer time course to the measured effect compared to the plasma concentration. But it's not a real concentration. I repeat myself over and over again. It's not measurable directly. It is an estimation of a new concentration that is closely related to the observed time course of effect. So now that we've constructed an effect site concentration that should have a closer time course compared to the actual effect, the BIS effect of what it's derived, you should expect the following pattern. If you increase your effect site concentration of propofol to higher values, then your BIS value will decrease according to the sigmoidal Emax curve, like it's drawn here in green. Then at a certain point we stop the pump and the corresponding effect site concentration will decrease together with the elimination of the drug out of the body. And the increase of BIS that follows the decrease in effect site concentration should follow more or less the same sigmoidal curve that was used for the induction. And so in optimal conditions there's no residual hysteresis anymore, no difference anymore between the concentration of an induction BIS or a recovery BIS. And even for loss and return of consciousness in optimal conditions, there should be one concentration that is correlated to that. Now, there are some problems with that concept, and this is deeply discussed in studies related to neural inertia. I will come back to that later during the lecture, but this is something that is rather outside of the topic of this lecture. The funny part is that even users of volatile agents start thinking about effect site concentration, because the advantage initially claimed by users of volatile agents versus the intravenous anesthesia, that the end-tidal measured vapor pressure in volatile agent titration is an individually measured reflection of the plasma concentration, and this is considered as an advantage because in the intravenous world we only can use a population estimation of the plasma concentration and not a real measurement. However, if we measure a simultaneous effect, we also see a considerable time delay between the onset and offset of effect versus the end-tidal measured concentration. And even in some ventilators, they added a reflection of the effect site concentration called the McBrain, and this has clearly considerable time delay to reach the same equilibrium in end-tidal vapor pressure as well as in the brain concentration. So this is really something new in the world of volatile agents. And look also during recovery, when you switch off the pumps, you are in equilibrium, McBrain and the end-tidal are equal. You switch off the pump and you expect recovery to 0.3 Mach in 2 minutes. But 2 minutes later, indeed, your end-tidal concentration has reached the Mach awake, but your McBrain is still very high, and every clinician knows that even if you reach the Mach awake, in your end-tidal vapor pressure, you need to wait for a considerable amount of minutes before your patient actually wakes up. This is because of the time delay. And so even in optimizing volatile agent titration, the use of a kind of effect site concentration is starting to appear. So far on the meaning of effect site concentration. We are now going to switch to a more practical side of the lecture, where we are going to check how we can make this theoretical mathematical solution for a problem of a time delay between a plasma concentration and an effect, how we can make this of value for ourselves as clinicians, and also how we can use it to the benefit of our patients. So if we talk about the value of effect site concentration, I see three advantages. First, it predicts the time course of a desired effect. And in anesthesia, we often look at the electroencephalogram as an objective quantification of hypnotic drug effect on the brain of the patient. For propofol, the canonical univariate index was used, which is not commercially available. And for opioids, they used the spectral edge frequency to develop the current commercially models for TCI. Although we predict a desired effect in the brain, it also has an influence on, for example, respiratory function and hemodynamics. I will show you an example in a minute. Secondly, the second advantage is we get a prediction of the average population effect. So although we do not predict the individual effect, this allows us to stratify the individual patient according to the sensitivity of his response to our drug concentration. I will give you an example to clarify this, but we will be able, by using an effect site control TCI, to diagnose the sensitivity of our patient in an objective way and adapt a titration for the remainder of the case. So a sensitive patient will receive less drug and a resistant patient will receive more drug than average. But in the end, this will result in a consistent outcome during maintenance and recovery of your anesthesia. And due to this increased reproducibility, we had a tremendous advantage of using effect site control TCI in many of our studies, and this results in very reproducible clinical effects and study results. And that led to very high ranked and highly cited study results in our research group. I will give also some examples. I can show you this first study. It's an older study already, but it clearly shows the difference and the importance of an effect site control TCI versus, for example, a plasma control TCI. In this case, we used propofol with a Schneider model in 20 or 25 patients, and we titrated towards a steady state effect site concentration of 5. And then we looked at the clinical effect, and as this effect site concentration tries to control the EEG, we measured BIS, and what do we see? That indeed the majority of the patients reaches targets that are close to 50, a BIS of 50, but there are some important outliers, both in the sensitive side and the resistant side of the spectrum, of the effect spectrum. And if you look at the clinical effect of loss of consciousness, there's an enormous spread in the timing of loss of consciousness. There's one patient who needs 10 minutes to lose responsiveness to shake and shout. If you compare this to the effect site control TCI, then you see that the BIS has, after steady state in the effect site, you see that the variability in the BIS is much smaller. And the outliers have been avoided due to the adaptation of the titration towards the effect site. And also look at the loss of consciousness. The timing of loss of consciousness is much more reproducible. I can't show you a more obvious proof that effect site control TCI improves the reproducibility of and the predictability of your clinical effects. Although the TCI pumps are modeled to maintain an EEG effect over time and to avoid overdosing in the EEG inhibition, It also is useful for other effects that are not into the effect site model. And this is confirmed by small studies, especially in a sedation setting, where a patient is breathing spontaneously and we want to avoid overshoot in our dosing to avoid apnea or respiratory depression. And both by a TCI remifentanil or a TCI propofol, it appears that this is successful in avoiding apnea and respiratory depression. In this study, we explored the relationship between the effect site concentration of propofol and the bispectral index. Also, some other auditory evoked potential index monitors were validated using this database, but that's irrelevant now for our discussion. So what do we learn from this kind of graphs? You see the relationship in 15 patients, 15 random patients with different demographic characteristics were given 300 milliliters per hour of propofol. From being fully awake, they went to deep anesthesia, and you see with increased propofol concentration that there's a consistent relationship with the average BIS in the population. It's a sigmoidal Emax curve, so there's a consistent dose-response relationship between your propofol concentration and the bispectral index. So the problem is, if you target towards an effect site concentration of propofol of 4, what will be your individual BIS? I couldn't tell you. You never know in advance whether your patient behaves according to the average in the population or will be an outlier. And so it might be that your individual patient has a BIS of 90, or if he is more sensitive to the drug, will have a BIS of 27. That's possible. So then you say, what is the predictive value of effect site concentration if he can't see the difference between a BIS of 27 and 90? Well, that's not what it's predicting. It's predicting the population average. And the population average here, for example, for a concentration of 4 micrograms per milliliter is around 55. And due to the Gaussian distribution of natural phenomenon, you see that the majority of your individual patients will behave close to the mean. And indeed, if you look at the majority of our patients, you see that they, sorry for the strange lines, they are within a range of, let's say, 45 to 65 BIS. So this study was done without opioids. If you add opioids to 4 micrograms per milliliter of propofol, you will end up with a BIS of 50, and the majority of your patients will be between 40 and 60. But now in this specific study, it was a little higher because of the lack of opioids. So, and a minority of patients is either a very responsive patient with a low BIS or a very resistant patient with a high BIS. And so these limited numbers of patients, they will need another effect site concentration to obtain the desired effect, being a BIS of 50. But that's what I call stratification of your patient towards their sensitivity. If you start 4 micrograms propofol and you know that you expect a BIS of 50, then you know that your patient is very sensitive when he ends up with a BIS of 27. And you know that this patient needs a straightforward adaptation of your drug titration for the remainder of your case. And this adaptation of your clinical practice will result in an improved outcome, both for the individual patient as for the population, because by doing so, you avoid outlier behavior during maintenance and recovery. And for example, you will have less unexpected recovery delays when you use this strategy for optimal drug titration. So this is an important issue, that the population average as predicted by the effect site concentration is not the individual effect, but that shouldn't be a big problem because of the Gaussian distribution of biological variables. You see that the majority of your population will behave close to the mean. So for example, in this green Gaussian distribution, the majority will be between margins that are clinically acceptable, and only a limited number will be outside that range. So if this, for example, if the red one would be the distribution for the BIS relationship with the effect site concentration, you would see that the majority is in a range between 40 and 60, and only a limited number have an excessive effect or an insufficient effect and need to be adapted. That's how you individualize the drug titration with the effect site controlled pump. And moreover, you have the ability to stratify your patient as a sensitive or resistant patient, and this also will adapt or will evoke an adaptation of the rest of your case, and you will give a lower drug or higher drug dose than average, but this will be in favor of that individual patient. So this is another way of representing the same message. If we set a single target, an effect site concentration of propofol in the population, the dose that will be delivered to reach that effect site concentration will be different between individuals because they have different demographic characteristics. And then we measure the BIS. Will we be able to predict the absolute value of the BIS of our first patient? Not at all, but we see the time course is very consistent between the estimated effect site concentration and this BIS over time. The second patient, also a very consistent time course description, but the absolute value is much lower, so probably this is a much more sensitive patient. And here is a much more resistant patient, but again, the time course is very consistent. And finally, you will find a patient who is close to the mean. And indeed, if you repeat this exercise over and over again, you will see that the majority of your patients is ending up close to the mean, which is a BIS value between 40 and 60 if you combine it with some opioids. So that's a big advantage of controlling the effect during effect site control TCI. The pattern will be completely different if you give a bolus and a continuous infusion instead of using effect site control TCI. And the reason is that the underlying effect site concentration estimation will be completely different. So initially, if you use a bolus, you will see a high peak in the effect site concentration, and this might result in an overdose of your clinical effect. You will not have this steady state condition in one step, but you will first see a peak then due to the elimination of the bolus of propofol, and if you're setting your pump too slow, you might end up with a zone of less anesthesia effect, and then at a certain point you will reach a steady state, but it will take much more time before you reach this steady state compared to TCI. And what will the corresponding BIS do? Well, for patient 1 it will be like this, patient 2 this one, and then the very sensitive patient will probably crash towards a BIS of 0 for a longer time and then only slowly recuperate from that. So what we see is that the time course of this BIS effect follows the estimations of the effect site time course quite accurately, but again we risk an overshoot in the beginning of anesthesia, and we have this later steady state condition. And we also equally will have to adapt our dosing for the sensitive and the resistant patient, but using an effect site concentration allows you to reach a new steady state also for these patients in 1 or 2 steps. And that's the advantage of effect site control TCI. Also, when you perform scientific research, the effect site concentration titration improves the reproducibility of your observations. And we in our research center in the University Medical Center in Groningen, we really performed consecutive studies using TCI effect site controlled titration to improve the reproducibility of our clinical findings. And we use this, for example, for validation of new EEG monitors, or like the recent analgesia indices. We use the effect site concept really to verify whether these monitors have sufficient signal to differentiate a sensitive and a resistant patient. And by titrating towards an effect site, we really can quantify the relationship between a range of controlled effects and a measurement on a monitor. Also, we have recently published a paper on equipotency conversion between volatile balanced anesthesia, or balanced anesthesia based on a volatile agent, or on propofol. And also this publication demonstrated very subtle differences between a TIVA anesthesia and a volatile balanced anesthesia, and we wouldn't be able to make it so reproducible if we hadn't had effect site controlled TCI. Interaction studies help us a lot for clinical practice. I'll show you an example in a minute. Also, the interaction studies were only feasible if we could titrate our intravenous drugs in an effect site controlled way. And we also have some interesting, more fundamental research questions that we challenged using the effect site concept, the challenge of the neural inertia. It would bring me too far to go into detail about these studies, but I have the references put on the slide, so you can, if you're interested in this kind of research, feel free to look it up for yourself. As an example, I show you the results of our interaction studies, where we were able to quantify the additive interaction between sevoflurane and propofol, and also the interaction between sevoflurane and remifentanil. And the study by Bouillon of propofol versus remifentanil, we combined these papers in one single interaction model, where we could see the where we expressed in a quantitative way how the combinations of, for example, a combination of propofol and remifentanil results in a probability of tolerating laryngoscopy and results in a certain BIS number. And so for me this is very valuable information, because if you want to start anesthesia and you start with remifentanil and you set your initial remifentanil concentration with the Minto model on 4, level 4, and you combine it with a combination of propofol with a 4 micrograms per milliliter effect site concentration, after equilibration you will find that the BIS is around 45. This is the additive, the dotted line is the additive line of interaction on BIS, and the full line here is the line of 60, a BIS of 60, and the dotted line here, the synergistic interaction that is shown here, is the 90% tolerance of laryngoscopy estimation. So with a combination of 4 propofol with the Schneider model and 4 remifentanil of the Minto model, and after equilibration you will end up with a 10% probability that the patient will still move on laryngoscopy, and it has a BIS of 45. I think this is a very good initial target combination to start a TIVA anesthesia. And I do this in daily practice. Every day I set my pumps and I start with 4-4 combination on a remifentanil propofol setting, and I see only in a very limited number of patients I need to adjust my propofol or my remifentanil a little bit, because at the time of laryngoscopy there is some hemodynamic response. And so this kind of interaction studies are really valuable for the clinic, provided that you titrate towards the effect site concentration, of course. This is the same graph as in the last slide, maybe a bit more clear for the viewer. So you see again, for induction of anesthesia, I set my pump at 4 remifentanil and 4 propofol, because it's a good combination where you have a probability of an average BIS in your population that ranges around 45, And so even due to the Gaussian distribution of the phenomena in nature, the majority of my patients will be around between 35 and 60. That's really the majority. I think 70% of my patients will be in that range with one step, and only a limited number will need less drug than this because they have BIS values below 35. Some will have BIS values above 60, and I have to adapt. Also, then I do a laryngoscopy, and if I see some hemodynamic response, I don't continue with the intubation because intubation is even a more severe stimulus. I will first stop the procedure and increase my concentration of remifentanil or propofol, and I will then restart the intubation attempt. For recovery of anesthesia, I set my targets to 1 nanogram per milliliter and 1 microgram per milliliter of propofol, so nanogram per milliliter for remifentanil and microgram for propofol. And this results in a very high probability that the patient will be responding to shake and shout, and because it's way below the 50% probability of tolerating shake and shout, and it also ensures respiratory function, a return of respiratory function in 90% of the patients, and it also ensures that the patient still has some residual analgesia. And this is a perfect combination to wake up my patients. It is a little bit depending on the severity of the pain of the surgery, but this is a really convenient way of titrating with 2 TCI pumps in the spectrum of effect site concentrations. This is another example where we studied the subtle differences in the effect of a combination of an opioid with propofol or sevoflurane in their ability to inhibit name calling, shake and shout, or tolerance to tetanic stimulus. And then you see that there's a clear distinction between adding remifentanil in a TIVA setting versus sevoflurane. The hypnotic effect of sevoflurane is not affected by the opioids. Neither 2 nor 4 nanograms per milliliter of remifentanil had any effect on the dose-response relationship for inhibiting the response to name calling with sevoflurane, but it did with propofol. And it's even more pronounced when you have a noxious stimulus. So there is a little effect of the remifentanil on the inhibition capacity for noxious stimulus when you use sevoflurane, but it's much less pronounced, and there was no significant difference anymore between 2 and 4 nanograms per milliliter. Now, this kind of subtle sensitivity differences between anesthetic conditions is not observable in scientific research if you are not using a very reproducible way of drug titration, and that's the effect site control TCI. This is an example of how insufficient control over your effect may be one of the reasons why a very expensive multi-center prospective randomized controlled trial that tried to establish an effect on mortality of a 2-deep anesthesia versus a normal anesthesia with a BIS titrated towards 50, and they didn't succeed in obtaining a BIS number that was significantly different between the two groups. And I'm afraid that this is the reality. We are in clinical practice, we are so diverse in our way of titrating drugs that the ultimate effects that we obtain on average there's an amazing range of effects that were obtained, and this is not significantly different. So you need more consistent, reproducible titration skills to be able to do a prospective study where you target towards a BIS between 40 and 50 and a BIS that is between 20 and 30, for example. So this is an example of a missed opportunity where a better methodology on the pharmacological level could have made a difference. It's a pity. How can effect site concentration be of any use during maintenance of anesthesia? In the past, there were some suggestions of giving a bolus of propofol and then decreasing continuous infusion starting from 10 milligrams per kilogram per hour for 15 minutes, and then switch to 8 milligrams per kilogram per hour, and then to 6 milligrams per kilogram per hour. And this anesthetic scheme of drug titration resulted in a rather steady plasma concentration around 3 micrograms per milliliter. Then you just had to adjust your opioids to cope with the noxious stimulus. The problem is, if at a certain point you suddenly feel the need to have more hypnotic drug effect, then you have to give an additional bolus or increase your continuous infusion, and then you are out of range. You have no idea anymore how your plasma or effect site concentration will behave over time. And this is a difference, of course, with an effect site controlled pump, where you just increase your target and all the complexity of the mathematics is taken care of by the pump. Also, when you decrease a little bit, the pump will go to 0 infusion speed for an amount of time, just enough to let the new drug target be reached and maintained, and then the pump will restart automatically. You can't forget to put the pump on again. And so it makes titration of the hypnotic effect or the analgesic effect through an effect site controlled TCI pump equally convenient as increasing or decreasing the vaporizer of your volatile agent. For the recovery of anesthesiology, the commercialized TCI pumps have a tool that is called a decrement concentration target. So you can set a target that is your desired effect site concentration to, for example, wake up the patient. And when I talked about the interaction studies, you can extract information from these studies which combination would be suitable for your goals. And so, for example, when I select a 1 nanogram per milliliter remifentanil in combination with 1 microgram per milliliter propofol effect site concentration, I know that in 90% of the cases my patient will respond to shake and shout, they will be able to breathe spontaneously, and they will have still a reasonable residual analgesia depending on the severity of the surgery. So I use these tools to have some idea of the amount of accumulation of the drug in the human body and how long it will take to decrease or to eliminate my drug. Due to a phenomenon which is called the context sensitive half time, the half time increases when you maintain your drug for longer duration in a continuous infusion. So this is something that can be calculated by the pumps. Very handy tool to optimize your recovery conditions. And by optimizing the recovery conditions, again, don't be mistaken, it is not your individual patient that you predict. That's not the recovery condition of your individual patient that you predict. It is your population average. And what my impression is that titrating towards these endpoints does avoid outlier behavior. You will, if you do this technique in 100 patients, you will have much less patients that are surprisingly taking a lot of time to wake up or start breathing or be responsive. And that's because using these pumps it avoids that you miscalculate and misinterpret the pharmacokinetic characteristics of your patients. That's what's the power of an effect site controlled population estimation of effects. I didn't speak about limitations and so on of this model derived PK/PD drug titration. And still there are some limitations, of course, and the most important one is that your model predicts a population effect and not an individual effect. But I think I could convince you that although you titrate towards an average, the majority of your patients will behave close to the mean because of the Gaussian distribution in nature of many endpoints, and only a limited number needs a little adjustment. And even for those patients, you will have done a good job because you individualize your drug titration. The TCI models only use a single effect, which is mostly based on frontal EEG, and this might be not relevant for other targets like blood pressure or respiratory function, but clinically we have the impression that if you have an equilibrium in your brain functions due to your anesthesia administered, you will also have a very fast steady state in other endpoints. That does not mean that you can predict every endpoint in advance. You still need to monitor and to cope with side effects. The TCI concept does not change the drug, and propofol will still have a hypotensive effect. So you need to cope with that as an anesthetist. And finally, there's a lack of, not all drugs have a TCI model, and certainly not in a commercial way or in a commercial device that is available for clinical practice, but there is continuous development of new models and new interaction models. For example, there's currently a study on dexmedetomidine and opioids that is going on. And finally, what I already mentioned in the beginning of this lecture, there's a limitation that there are multiple models for different populations. And even for the same population, there are multiple models, for example, the Marsh model and the Schneider model for propofol, both describing the pharmacokinetics for lean adult patients, and they even use different covariates. That is all very confusing for people who are not expert in the domain. And the selection of models really hampers the wider application of TCI in clinical practice. So also for the difficult populations like the obese patients, there's not a real good solution. The teenagers, there's not a real good solution because there's scarce data on the teenage pharmacokinetics due to the massive different demographic range. And then also the pharmacodynamic sensitivity, both in elderly and young, are considered consistent in the current PK/PD models, which is also a bit counterintuitive, as we all know that elderly seem to be very sensitive to propofol, for example. So this is all included in a new evolution where general purpose models for both propofol and remifentanil have been described in recent publications in 2018 and 2017, both for remifentanil and propofol. They are developed by engineer Douglas Elleveld, who is also working in the University Medical Center in Groningen, and he developed based on a large database containing much more studies combined from all over the world, giving some information on the relationship between the propofol dosing and the subsequent effect and the plasma concentration. This is a much more solid description of the mankind's response to propofol and remifentanil. They found much more subtle covariates like fat-free mass, which copes with the problem of lean body mass. Lean body mass is not included in the algorithm, so probably the prediction of the plasma and effect site concentration in obese patients will be much improved. They used a concept called allometric scaling, which is a way of coping with scarce data or extrapolating of the results of your prediction of your model towards demographic combinations that are not available in the data for model development. And also they found that for the elderly, the sensitivity for propofol in the pharmacodynamic domain, so the Ke0, becomes dependent on age. The equilibration constant for that describes the relationship between plasma concentration and effect site concentration is depending on age. And this is very important because the older you get, you should put lower targets, effect site control targets, to obtain a steady and a steady concentration of effect or steady effect. All this information is very early. These models are soon to be available on a commercial level and will be available for all the clinicians to use. So it is too soon to see the impact of this on the use of TCI, but I'm convinced that it at least will revive a new interest in the concept of optimal intravenous drug titration using effect site control TCI. So in conclusion, the advantages of TCI is that we use the concept of effect site concentration. This is the evidence-based form of optimal drug titration. Even for volatile agents, the adding a McBrain or the effect site concentration of your sevoflurane to your information is an improvement for optimal drug titration. It is easy to use. Administering intravenous drugs using a TCI pump makes it equally convenient as turning the knob of your volatile vaporizer, volatile agent vaporizer. It is equally convenient. And we have very solid interaction models that can be made of use both for the volatile agents as well as for the intravenous agents, but you should use effect site concentration to really make advantage of this information. And so this is a very important progress. And then the quality of the models that are available are improved continuously. So I'm really looking forward to the general purpose models that soon will improve the accuracy of these or the reproducibility of the effect even more compared to the current models that we have available. So, and this brings us to the end of this lecture. I hope you all found this very informative. I thank you very much for your attention and that you maintained your attention till the end. I'm open for questions. You can always reach me by email, and I'm open to answer them if I'm able to. Looking forward for our next meeting in another lecture that I plan to post online. See you later and have a good day.